It is a great pleasure for me to introduce my colleague and friend who will be our inaugural talk, also our international contributor. Dr. Agatino Battaglia is head of research at in neuropsychiatry at the Stella Maris Institute, which is near Pisa, Italy. I've had the great pleasure of visiting him there. The Stella Maris evaluates children with developmental disabilities and is a quite comprehensive center and institute. Dr. Battaglia is also contact professor of child neuropsych at the University of Pisa in Pisa, Italy, and is an adjunct at our University of Utah in the Department of Pediatrics, and also is an adjunct professor at the Sanford School of Medicine in University of South Dakota, which interestingly has sponsored and hosted a soft meeting in the past. So Dr. Battaglia has a very interesting and rich past. He is a pediatrician, a child neurologist. His early part of his career was devoted to the care and treatment of children with seizure disorders and epilepsy. He still continues down that path, but about 25 years ago, he began having a very deep interest in genetic syndromes, seeing how so many children with developmental disabilities had syndromes, and that began his road now in medical genetics and dysmorphology. We had the pleasure together to host a small meeting in Pisa, Italy, of families with children with trisomy 18 a number of years ago, and hope to do that again. Dr. Battaglia will deliver a talk on the spectrum of epilepsy in the trisomy 18 syndrome. Buonasera, Agatino, and we welcome you joining us today from Italy.
Thank you, John, for this very kind presentation, introduction, and buongiorno to all of you in US. Now, the occurrence of seizures and/or epilepsy in full trisomy 18 may constitute one of the most important challenges. However, in literature, there is literally very little about the age at onset of seizures, the seizures semiology, classification of the epileptic syndromes, and seizure prognosis. The data I'm going to show you today are coming from two small retrospective studies performed by Dr. Kumada and colleagues in Japan and by Dr. Matricardi and colleagues in Italy. Altogether, they studied 29 individuals, 12 males and 17 females with the full trisomy 18. They were aged between 14 months and 11 years, and age at seizure onset ranged between 3 days and 3 years and a half. And they divided those individuals into groups. Group 1 included full trisomy 18 with associated brain abnormalities, and Group 2 included individuals without brain abnormalities. And as you can appreciate, 30% of the 20 individuals with brain abnormalities had infantile status, with age at onset ranging between 1 month and perhaps 2 years. And here you can see the brain MRI and the EEG of one of the patients, of the Japanese patients studied by Kumada et al. On A, you can see a brain MRI carried out at 3 years, 6 months, and showing mild diffuse cerebral atrophy. On B, you can appreciate an interictal EEG carried out during sleep at 3 years and 3 months, and showing a full-blown hypsarrhythmia. And after 1 month therapy, on C, you can appreciate how the hypsarrhythmia is no longer seen. One more Japanese individual studied by Kumata. Again, on A, you can appreciate the brain MRI showing a diffuse cerebral atrophy more prominent over the right hemisphere. And consequently, the EEG shows a so-called modified hypsarrhythmia, which is hypsarrhythmia over the left hemisphere and a very low amplitude background activity over the right hemisphere, which is well in keeping with the more prominent cortical atrophy. Now, of the 20 individuals with brain abnormalities, most of them showed more than one seizure type. These were mainly focal motor seizures or complex partial seizures, and all had a high seizure frequency at epilepsy onset. They were daily seizures. And most individuals had multifocal EEG abnormalities. And all but one of these individuals developed drug-resistant epilepsy. 60% of them were receiving poly-antiepileptic therapy, including carbamazepine, levetiracetam, topiramate, valproate, lamotrigine, vigabatrin, and benzodiazepines. 2 individuals also received ACTH and hydrocortisone, and only 5 received monotherapy with either phenobarbital or valproate or carbamazepine. The brain abnormalities were represented by cortical atrophy, porencephaly, perisylvian polymicrogyria, corpus callosum hypoplasia or agenesis, vermis and pons hypoplasia, and simplified cortical gyration. And here you can see the brain MRI of one of the Italian individuals studied by Matricardi and colleagues at 3 years old. And on the left-hand side, you can see a T1-weighted sagittal sequence displaying posterior CSF collection with hypoplasia of pons and of the vermis and thin corpus callosum. And on the right-hand side, a T2-weighted axial sequence displaying enlargement of the ventricles and of the sulci. Now, taking into account the individuals, the 9 individuals with full trisomy 18 without brain abnormalities, you can see how they had only one seizure type, and these were either focal or generalized. Seizure frequency at onset varied from daily to monthly, and only 2 of them had multifocal EEG abnormalities, where 3 had focal EEG abnormalities. 5 such individuals were treated with 1 antiepileptic drug, 2 of them with 2 antiepileptic drugs, and 1 of them with only 1 seizure received, of course, no antiepileptic drugs. The most used antiepileptic drugs were either valproate or levetiracetam or benzodiazepines. At the end of follow-up, all but 2 individuals had a good seizure control and a normal EEG. So you can appreciate how drug-resistant epilepsy was found in 90% of full trisomy 18 individuals with associated brain abnormalities versus only 25 of those without brain abnormalities. And the median age at seizure onset was significantly lower in those harboring brain abnormalities versus those without it. Again, multiple seizure types and more focal seizures were seen in individuals harboring brain abnormalities versus single seizure type in those without it. Seizure frequency was higher in individuals with brain abnormalities versus those without it. And the outcome was poorer in individuals with brain abnormalities versus those without it. Monotherapy seems to be successful in individuals without brain abnormalities. Concerning health supervision in full trisomy 18, we would strongly recommend performing waking sleeping video EEG polygraphic studies in order to study in the best way the most accurate seizure semiology, in order to treat them with the first choices drugs. In addition, in the presence of seizures, brain MRI should be mandatory since malformation of the cerebral cortex may modify prognosis and management. In conclusion, epilepsy seems to be a component manifestation of full trisomy 18. And as there is developmental progress in the survival of children with the syndrome, a more detailed knowledge of the neurological phenotype is mandatory in order to effectively plan specific health supervision. We would strongly recommend further studies of larger cohorts of individuals with full trisomy 18 in order to better understand the natural history of seizures and the entire spectrum of seizures and EEG findings in such individuals. I thank you for your attention and hope to have been clear enough. Thank you.
Agatino, grazie mille. I'm going to take the chair's prerogative and ask you a question or two, and then we'll open things up for the audience as they might want to put things in the chat box, or at least in the beginning, perhaps raise their hands. So I recall the paper from Italy from Matricardi, if I'm saying his name correctly. And as you pointed out, the important correlation between those having brain abnormalities on MRI versus those that don't. So there are some MRI findings that occur relatively commonly in trisomy 18, some of them detected on prenatal ultrasound, which include an enlargement of the cisterna magna, perhaps maybe some excess fluid in that area, and dysgenesis or changes in the corpus callosum. Would you consider those findings, which tend to be relatively common on prenatal ultrasound, are they part of that list of what you and Matricardi defined as brain abnormalities?
Can you please repeat the question?
Yes, I was wondering what comprises being a brain abnormality on MRI, because changes of the corpus callosum and enlargement of the cisterna magna are quite common. And
yes,
so,
I see what you mean. Yes,
and
yes,
therefore, I'm wondering what are the brain findings that are most predictive if we were to move to doing routine MRIs in infants with trisomy 18 for prognostic reasons, what would be the findings that you would put the most weight on?
For instance, the perisylvian polymicrogyria, and particularly the simplified cortical gyration. Let's say I would put a weight, particularly in relation to the possible etiology of seizures on the brain cortical abnormalities, such as perisylvian polymicrogyria or simplified cortical gyration. That's one reason, one of the main reasons for which I think that we really need to perform more detailed studies on much larger cohorts of full trisomy 18 individuals. Because, as you said, corpus callosum agenesis or hypoplasia are certainly not per se seizure triggers, if you see what I mean.
Right.
So we should really have a larger cohort of patients in order to make much more detailed and much more specific, let's say, a correlation between the type of a brain abnormality and the occurrence of seizures, if you see what I mean.
Yes, thank you.
The point is that actually both studies were retrospective studies, but let's say Matricardi studied 18 patients and Kumada 11 patients. But you know what? All these patients were coming, one from a different pediatric neurology department. Therefore, no one of them had such a large and good experience in order to specify all we were discussing. You see what I mean? Because 18 patients were coming, one each from 18 different pediatric neurology centers. You see what I mean?
See, yes.
So I would like to launch on this occasion a detailed study, perhaps starting with the soft families, in order to be able to study larger cohorts of patients, but in a very detailed way. Because if I pull together 18 patients coming, each one from a different center, retrospectively in addition, you can understand that at the end we have really very little in our hands. So I think, I hope that this presentation might be a trigger toward, let's say, the soft institution, the soft family group, and hope that they might be willing to start such a study, which, if you wish, we might drive together.
Thank you. And as I mentioned to you, there was the chromosome 18 registry collaborated with SOFT and actually sent out a survey that was very general and broad. But in that survey, it did actually query the number of people who had seizures. So that would be a launching pad, a starting place. But we can talk about that, and we can talk about it with the Medical and Scientific Advisory Board. But yeah. I have two more questions, but I'm going to hold those questions in deference to two questions that are together in the chat box. And I think, Kelly, I think if it's possible there's two related questions. If I'm saying your name correctly, I apologize. If not, by Stefetra, and maybe you might unmute Stefetra and let that question, rather than in the chat box, just be on live.
So, Dr. Carey, Stefetra is one of our parents, and I think basically, if I'm going to sum up her question, she looks like she's more so inquiring about, in addition to pharmacological treatment of seizures, also mechanical treatment of seizures. So she's referencing like a VNS device, and kind of where those things would fit in and when you would transition from using a lot of AEDs over to using some of the different methods.
Which method? Sorry, I couldn't hear clearly. Which method?
So her question in the chat box, she was asking about using different medications, but then also using more mechanical devices. So she references a VNS. And I think she was wondering when that would be indicated, or if you saw more of that in trisomy 18.
Well, once again, we do not have specific studies on this. That's the point. That's what I was telling before. The only data we have from the literature are those that I have been showing. So we have no real data on this. That's why, again, I would suggest participating in that study I am proposing. Actually, we did the similar study with other genetic conditions, such as deletion 1p36, deletion 4p16, or Wolff-Hirschhorn syndrome, such as the EDIC-15 syndrome, and so on. We have simply no data.
Right, and I think that from talking to
and then
families.
Sorry. Of course, it depends on an individual basis, because we have to see the general condition of the patient, how many seizures, what kind of seizures, what kind of EEG, and so on. So it is not so simple. Anyway, we have no data in the literature. So, John, sorry, go on.
Oh, that's okay. Just in talking to families around the country over the years, I think that there hasn't been any particular platform related to trisomy 18 or even trisomy 13 for that matter. So I think our neurologists all around Europe and America simply follow what they can in the usual way. And so if someone has intractable seizures after multiple medications, there might be the devices that are placed for seizures like in any child with complex seizures. But I don't think we have any guidance specifically, right, about trisomy 18
no,
in this regard.
No.
So there are two other questions, one from Brad Smith and one from Steve Cantrell. So Kelly, for Brad, did you want to let him speak, or should I read his question?
You can read Brad's question.
Good, okay. So Agatino, Mr. Smith asks, though not in the study presented, are you aware of any information regarding trisomy 18 and puberty hormone-related onset of epilepsy? And also, is there any information related specifically to Lennox-Gastaut in trisomy 18? So puberty was one question, and then anything about Lennox-Gastaut in trisomy 18 was the second.
Okay, as far as I am aware of, there is no mention of the Lennox-Gastaut syndrome in full trisomy 18. Although, again, when they say that most of individuals with associated brain abnormalities showed a drug-resistant epilepsy, I would really like to go and see the EEG of those individuals. But unfortunately, in that study, there is nothing about the EEG findings. So that's another great limitation of that study. So once more, I would really pursue the study I was talking before. And then for the other question, I'm not aware of anything concerning that one.
concerning puberty.
Yeah.
I think we know that puberty sometimes brings out, or is the time of idiopathic epilepsy. So you can imagine, perhaps, maybe, but again, we know we're talking about 12, 13, 14, 15-year-olds of either gender, and we even have less knowledge of that.
This usually can happen, particularly in the female patients. But I mean, it is something very well controlled, very well treatable. If there is, on occasions, there isn't even no need to treat them. Anyway, I'm not aware of such a condition in full trisomy 18. But let's say, as you know, John, although I have a great experience with other genetic syndromes, my experience with full trisomy 18 is very, very limited. So,
following up on Brad's question about the Lennox-Gastaut, given the variety of seizure types that you described from the series, even those with and without brain and abnormalities, it would not surprise me that perhaps maybe we would see the Lennox-Gastaut presentation of those types of seizures in EEG in trisomy 18, since we see it as part of other genetic syndrome. So it wouldn't surprise me necessarily if we saw the range of our spectrum to include Lennox-Gastaut, even though I don't personally know of anyone who had that pattern with trisomy 18. So it's a good question again about the specificity of potential specificity, which by presenting the two studies you gave us some feeling for, but there's so much unknown.
Yes, as I said, there is very much unknown, particularly because we well know that, for instance, patients, individuals with infantile spasms associated with hypsarrhythmia, if do not respond, let's say, immediately to the pharmacotherapy, can well develop the so-called Lennox-Gastaut syndrome. But anyway, the point is that we do not really know anything about this kind of epileptic seizures in full trisomy 18, because again, there are very little data in the literature. So one more reason to go on with the study I proposed before.
Right, so just to follow up on what Dr. Battaglia is referring to here, that he alluded to earlier, in the other syndromes where he has worked on the specifics about seizure patterns in Wolf-Hirschhorn and the 1p36 and so on, he went to the trouble of collecting the records, MRIs if possible, their EEGs if possible, or at least the reports, and actually was able to describe more specific patterns associated in those syndromes. And I could see the same kind of work being done both in trisomy 18 and in trisomy 13.
We should really do it, John.
Thank you. The next question is from Dr. Steve Cantrell, who's also a member of our board of SOFT.
Dr. Carey, I'm going to bring him on so he can ask his question.
That would be great. Well, please bring Steve on. That'd be great.
Dr. Cantrell, if you can unmute yourself. There you go.
All right. Am I unmuted?
Yes.
You are.
Let's see. Well, I am. Good. Thank you so much for your presentation this morning. This is wonderful. Good news. And I do encourage a collaboration with SOFT on this topic. My question is, do you find light-triggered seizures or photosensitive epilepsy to be common with trisomy 18?
No, not at all. Not at all. If I am not wrong, I read of one such occurrence only in one patient, so it does not seem to be a common feature.
But again, we're studying
Our
because
children,
denominator is so low. Go ahead, Steve.
yes. Well, I was just going to comment, over the years, our children, I am an optometrist, and I've been observing for a number of years the children with painful light photophobia. And we've been using sunglasses, particular blue blocking sunglasses that have been effective in reducing the painful light. And recently, we are exploring contact lenses for a 24-month-old that was diagnosed with photosensitive epilepsy at Vanderbilt that have been effective. So I'm thinking this may be a thread, but we're not sure.
And of course, the child has full trisomy 18, am I right?
Yes.
Okay, it's interesting, yeah. Okay.
So Agatino, Stefetra has another question here. She had asked a question earlier about the surgical devices. Does trisomy 18 and 13 have similar health problems with seizures? And then she thanked you for giving the presentation.
Thank you, but did you make a question?
Yeah, do trisomy 18 and 13 have similar health problems with seizures? That is, are the seizures, I think what she's asking is, are the seizures related in trisomy 18 and 13 the same kind of medical problems as they are in kids with seizures in general? I think an example of what she might be asking is, which we don't know the answer, would be like, do we in fact see status epilepticus? Would be an example of similar health problems that might occur with seizures. We don't know, I think.
I mean, as I said, now let me see. Didn't say nothing, non dice nulla. I mean, these two studies are so scanty that, let me see, are so scanty, these studies, very scanty indeed. They say very, very little, very little. I do not have enough material to answer this question. So again, we have for sure to go on with our detailed study. Anyway, it may well be, but no one of those two studies say anything about the occurrence of status epilepticus.
Well, that was just something.
It may well be, but we cannot say. We do not know.
Right.
If was this the question?
Yes. So, Dr. Debbie Bruns has a comment which I think is really important. Kelly, can you unmute Dr. Bruns?
Sure.
Or maybe she can unmute herself. So Debbie, if share your point, I think it's really important and maybe even a better avenue for what Agatino's talking about.
Can you guys hear me?
We can.
Okay. And I guess if you can give me a visual too, that would be great. I just commented that I'm the lead researcher with the Tracking Rare Incidence Syndromes project, and more than happy to share data as I have longitudinal seizure and epilepsy data for some of the children and adults with trisomy 18. So talking about 6, 8, 10 years of data potentially with onset of seizures, medications that have been tried, outcomes, and so on. So more than happy to help with this effort.
Thank you. Thank you very much.
Yes, thank you, Debbie. I think that's actually, Trice would be a great platform for initiating the kind of retrospective study that Agatino mentioned.
Glad to help.
Thank you.
Thank you.
So I don't see any other questions in the box. Kelly, am I missing any other questions or comments?
No, we hit them all.
Well, Agatino, I had a question. I was saving it. I think they're kind of similar to the ones that people were already asking. So you mentioned the various medications that have been used. You know, when you cited one of the two papers, I think it might have been the Italian series. From reading the papers, did you get any feeling about a preferable medicine or anticonvulsants that we would not use? Kind of that you determined that in Wolff-Hirschhorn syndrome that we shouldn't be using carbamazepine, and there were other medicines that were better. I suspect you didn't get any feeling for that from those papers, from my reading.
Your suspicion is quite right.
Because I do know that in going and talking to families at SOF conferences over the years, that there were in children on seizures, there seemed to be a high frequency on Lamictal, the tromagene. It just seemed more common but I can't tell you what type of seizures they had, just that seemed to be the medicine that many ended up on.
Yeah, no, from these two studies, you cannot really get any idea of which one drug was the best in controlling seizures. Actually, you cannot get any idea at all. No.
So one other question for you, and that has to do with there's at least one report in the literature of a child with trisomy 18 that was thought to have central apnea, but on further examination, it turned out that she had seizures that, when treated, actually resolved what was thought to be the central apnea. Do you have any comments on that? Have you heard of that or had any other experience yourself with that?
Yes, I had one such child with deletion 1p36, and she had epileptic apneas. And that's why it is very, very important to perform as soon as possible a very detailed video EEG polygraphic study, because it is the only way of making the right diagnosis. And of course, if those apneas are epileptic ones, you can really control them in a very good way. And as I did with that small patient of mine with deletion 1p36. Yes.
Thank you. So any other questions from the audience that they can raise their hand, I think, the health professionals, or put a question in the chat box.
As of right now, we don't have anybody with their hand raised, and we've addressed all of the questions that were in the chat box.
Good. I think
I really hope to be able to participate on the next participate to the next soft meeting, but in person, not just virtually.
Thank you. That would be great. I think, Dr. Battaglia, I know that you're leaving town right after this, but
Yes.
I'm going to forward you Debbie Bruns's email, and so we can begin to make that connection, perhaps in using the registry that she created, called TRIS. She's published a number of papers on TRIS in the American Journal of Medical Genetics. You may have seen them along the way, but they weren't about seizures specifically. And I think that probably may be the most ideal platform for beginning such a study that you have been articulating.
Yeah. Yes.
Thank you, Dr. Battaglia. We really appreciate you presenting for us.
Thank you. Bye-bye.
Well, good. If there are no other questions, I will again acknowledge Terry and Kelly for the great work in orchestrating this for the week, and I look forward to the all of the virtual conferences for the next week.
Thank you, Dr. Carey.